Well, good morning, everyone. We're here with the San Diego Spine Foundation Monday morning lecture series, and super excited to have one of our very own presenting this morning, Dr. Hani Malone. Hani, thanks for being here this morning. Hani's been part of the program now for many years, so he's now fully ingrained and entrenched, and it's been a marvelous thing to have both neurosurgery and orthopedic surgery in our fellowship program. And Hani, so grateful for you and all you do for this program. If you don't mind, Hani, you're going to talk about a topic that gets the #1 hit on the site, which is spinal fluid leak management. Something
Yeah,
that we all want to be known for. Thanks for taking the hit for us. But hey, you want to give
yeah,
us some of the take-home points for the day?
absolutely. So, like you said, Greg, it happens to everyone, and it is a funny thing for patients to come into the office and say, "Oh yeah, I saw your video on CSF leaks. Is that going to be part of my surgery?" And the answer is almost always not, and hopefully not, but it does happen to everyone. That being said, I do think that there's a lot you can do technique-wise, particularly with the kerrison and with dissection to limit it. So it's important to be mindful of that. But when it does happen, and it will happen to everyone, there's no better time to fix the injury than at the time of the actual durotomy. So I think that's important, not to just sort of try to cover it with DuraGen and pretend it didn't happen, but to really kind of collect yourself, dig in, and make sure you do everything that you can to repair the injury. And if you can't get a really good watertight closure, I think it's important to be ready to use a spinal drain, to understand how to use them and manage them so that you can make the issue as painless as possible.
Awesome. Well, without further ado, we look forward to your lecture. And thanks for this morning. Appreciate you, man.
Of course. Okay, so Greg mentioned in the intro about neuro and ortho working together. I think in my opinion, I think training for spine should really be ortho and neuro combined, and one of the best ways to get comfortable handling the dura is when it's in a controlled environment, when you're actually intending to open the durotomy. And so hopefully we'll all get a chance to scrub on some of these cases, and you can get some experience closing the dura. This is a photo of Ryan, who's an orthopedic fellow, and I was like trying to tell him how to do it, and he just kind of did it on his own better than I usually do, and I was really impressed. But I know Nick had a really good closure recently, so it's something that hopefully we'll get a chance to practice, because when it happens unintentionally, oftentimes the attending will sort of take over, and that's probably appropriate, to make sure that you get the best closure possible. But in this plan setting, obviously it's a lot more straightforward and a good opportunity to just get used to handling the dura. So, obviously the planned durotomies are in a nice linear capacity, but unplanned durotomies can present themselves in a host of different ways. You can get a little bleb. It can be by the axilla, and it can be a lot more challenging to repair. So you just have to have a couple of techniques up your sleeve so that you can do so with confidence. So how often does this happen? There's no consensus in the literature. There's actually a pretty wide range. It is definitely common. There are some studies that suggest the incidence is 1%. There are others that suggest 17%. I think that 1% is probably low, although I think you can get there. I think 17% is ridiculously high, but there may be certain practices where that is in fact the case. I would encourage you to actually keep a log in general of your cases, but track things like spinal leaks, and then you can share with patients what the actual incidences in your hands. And those of you who have been in clinic with me, I usually say around 2%, and that is pretty accurate from my own log. Certainly, if you have an elder patient that's got calcified flavum, or it's a revision, those are going to significantly increase the rate. And so if it's a revision decompression, sometimes I'll say 3 to 4%. But it's just important to have some statistics that you feel like are accurate. And I do think it's an important thing, even for just simple laminotomies, to discuss preoperatively. So, I don't get into every single possible complication in great detail, but I do pretty much always talk about spinal fluid leaks, what it means, what it would mean for their recovery. So God forbid, when that 2% or, that 150, when it does happen, it's not a huge surprise to them, and they already have a sense of what it will entail. So this is interesting because there's a pretty wide range, like we discussed. So some of the best literature actually comes from overseas. They did a prospective study in the UK where they looked at over 1,500 cases. It wasn't a single institution, and they have some more granular data. So again, this is higher than I would expect, but it is probably the best study that looks at it prospectively. They get 3.5 for discectomy, 8.5 for spinal stenosis surgery. That seems pretty high, but nevertheless, that's what they produced. And then 13.2% for revision discectomy. So I would expect that sort of increase from discectomy to stenosis to revision, but a little bit higher than I would expect. And my hope is that with the right technique, you can lower those numbers. It's also possible that it's a complication that's quite frequently underreported. And so I don't know. I mean, I often think like an interesting way to actually get good data would be like the use of Duragen or some of the sealants that we have, which we'll cover. But just to say that there is a variation, I think you can get better than these numbers with technique and just care. This is what I was discussing about collecting your own data. So this is just my the Excel spreadsheet I have on my computer, and I have a complication column. Sometimes, you'll go a long time with no complications, and then you'll get 2 durotomies back to back, like I did in March of 2021. It's just good to be able to track that and be confident in your own data. And then, you can maybe introspect, what was I doing? Was something about that day? Is it just bad luck, and so forth? And then, yeah, I think it's important to collect your own data because this is something that's probably tracked. Obviously, insurance companies, keep a lot of data on all of us. With AI, this is something that's pretty easy to pick up in the op reports just through like natural language processing identification. In fact, Dan Scuba and his group already did that. They looked at over 1,000 surgeries just using this AI model and found higher than I would expect, 8.4% risk. So, if it is something that is that high, it certainly merits a discussion preoperatively, just so that patients are well informed. The good news is that unlike a neurologic injury, this is something that you should be able to repair and not influence the patient's overall outcome. Although, of course, we know that it increases risk of infection, length of stay, and so forth. So what are the risk factors? Well, increased surgical duration. It's a bit of a catch-22 because if you have a CSF leak, obviously it's going to increase the duration. Older age, there's no question. Dura just loses its integrity. If you do cranial neurosurgery, this will be very obvious to you because the dura, oftentimes, when you have a big dural repair to do in the cranium, with older folks, it can be really difficult. It can become almost like tissue, paper, whereas with young patients, it's very strong and robust. Revision is a huge risk. And then case that starts after 4 p.m. So that's sort of an interesting outlier. And you can think about the, just sort of the social and environmental factors that could cause that risk when you're doing cases late in the evening. One thing that was not evaluated in this study was synovial cysts, and I think it probably merits some attention. Synovial cysts can be really adherent to the dura, and trying to take them off en bloc, particularly if they have hemorrhage, can be kind of a setup for CSF leaks. And so if you've got one of those cysts that's extremely adherent to the dura, oftentimes the better part of valor is just to sort of decapitate the cyst and leave a little rind stuck to the dura, which won't cause compression, but at a minimum won't create a significant risk of CSF leak. Okay, so not risk factors. I think the first one is super important. It's not a neuroortho thing. It happens with the same statistical significance for both groups. They did not find a PGY level association in that study that Shuba did. Hopefully that reflects, appropriate sort of escalation of responsibility. They're more locked in with the younger residents so that it happens, with no greater frequency there. No association with mean years as a surgeon. I would expect this to get better with time, but it could be that, it gets better and then it starts to get worse again. But there was no association with years of training. And then no association with mean BMI. I'm a little surprised by that. I think certainly in the MIS context, the longer the tube, the less you always sacrifice some dexterity, especially when you're getting to 7 centimeters and beyond. But they didn't find that in their study. They also didn't dichotomize between tubular and open decompression. So that may be part of the reason as well. So, I think when we think of durotomy, we often think of it as a minor complication. And if it's appropriately managed and it's not some, catastrophic durotomy, it should be a minor complication. But if you look at medical legal literature, it's a pretty significant portion of malpractice cases. So, um, it was the second most frequent, actually. So something to just keep in mind. And if it does happen, you want to be honest about it and really just do your absolute best. Okay, so what are the consequences? Well, obviously, it can be symptomatic. Probably the most symptomatic phenomena is headache. It does significantly increase the risk of meningitis, which we know, and that is particularly true if you have compromise of the wound. And so if you have CSF leaking through the wound, that's somebody that really needs to be admitted, needs to be started on antibiotics, because if they get meningitis, it goes from, a relatively low risk or not significant complication to a very significant complication. So always be very mindful of the wound anytime you have a CSF leak. For example, when I do intentional durotomies, I'll often close with a running nylon, just because I know that the integrity of that closure will hold over time if I need to leave the stitches in for 2 weeks or so. It does increase the risk of new neurologic deficit. I'm not quite sure how to interpret that in terms of the data that we have. I think that egress of CSF should not increase the risk of neurologic deficit, but perhaps if you get a compressive pseudomeningocele, or if during the closure there's some kind of issue with neurologic structures, then certainly that would make sense. But it should not necessarily increase the risk of neurologic deficit. It does, of course, oftentimes create a pseudomeningocele, which can become infected, can compress neurologic structures, and so something that you'll have to be mindful of. Okay, so in terms of the actual data, it certainly affects quality of life scores and higher levels of dissatisfaction. That's not a surprise, but it's pretty dramatic. It can increase the rates of dissatisfaction up to 50% higher, and obviously increase the cost of stay. Certainly, if you have an outpatient disc and all of a sudden the patient's in the hospital for a couple of days with a lumbar drain, that's going to dramatically increase the cost. This image of Hulk Hogan, I don't know if any of you guys ever heard about Hulk Hogan and the Laser Spine Institute. Fortunately for some of the fellows, you're coming into practice where the Laser Spine Institute isn't really a thing. They're now defunct, but it was actually this entity that was nationwide and had like a huge marketing campaign. I think they may even had like a Super Bowl commercial. But their model was not great. And I think a lot of patients didn't have great experiences. And Hulk Hogan is the one that actually brought them down. There was some like $50 million lawsuit where he had a CSF leak, then a spinal cord stimulator or something like that. You can read about it. It's not private, but anyways. So length of stay, antibiotics, revision surgery, those are things that obviously increase cost, significantly. And if you look at the actual data, it's about $4,000 higher per patient, which is a 67% increase. If you look at the Pearl Diver database, which is basically a multi-payer data set, it can be up to $10,000 higher, which is more than 100% of the index costs. And then if you actually don't fix the problem at the time of the first admission and the patients have to come back to the hospital, then that's going to obviously increase the cost dramatically, more than twice the original surgery. So, okay. So we know what's going to happen. We know that it can be a small complication if handled appropriately. It can also turn into a more serious one if not handled appropriately. We know it doesn't matter if you're ortho or neuro. We know that it can happen if you're the most experienced surgeon or if you're new. And it doesn't matter if you're training in a residency or fellow program. So basically, it's going to happen no matter where you fall in that sort of dichotomy. So like we said, it impacts quality, it impacts satisfaction, it impacts cost. So we have to keep it this minor complication, not let it become a more serious one. I know we discussed this a little bit in the main takeaway points, but I think that this is actually critical, particularly during your first couple of years in practice, guys. Like, it will happen, and when it happens, you just kind of have to take a second, put a cottonoid, put a piece of gel foam on the leak, collect yourself, don't panic. You're not a loser who was husky growing up and whose mother always loved your sister. Yeah, I wrote that probably in a moment of darkness. I don't know if any of you had to wear husky jeans when you were in middle school, but I did. It's really You're not a loser. Don't panic. Collect yourself and get ready to prepare it, because you're going to repair it. You're going to do a great job, and this is, the beginning of that. So,
thank you, Hani.
really
I feel better
important.
about myself now.
Oh my gosh, yeah. My mom's like, "Where do you keep your husky jeans? My son needs husky jeans." Like, Mom, no, I don't. So this, I think, is an important one, and obviously it's it's a funny slide, but I think especially if it's not a serious leak, you can be like, oh, maybe that's just a little bit of synovial fluid, or maybe that's just an irrigation. If you have a concern, try not to fall into the trap of, oh, like I'll just put a little something over there and it didn't really happen, and close up and it'll probably be fine. Listen, the reality is sometimes it probably will be fine, but I think you have to, if you have concern, investigate it and look at the situation. Obviously, try not to do anything to make it worse, but at least convince yourself that there's not a leak, or understand the leak that is present. And if there is a leak present, make sure that you're doing everything to optimize the outcome and minimize the potential consequences before you close up. And don't just try to cover it up and pretend it didn't happen. Okay, so let's get into the actual nuts and bolts of what to do. So I think it's important first to just kind of, say it's a pretty clear leak, for example. Get some kind of cover on it. I like to use gel foam just because it's not going to introduce anything into the dura, but it does create at least some tamponade. It actually has some substance. So I'll put a little piece of gel foam, maybe a patty over the gel foam, just sort of cover it. Realize that this has happened, collect yourself, kind of think about where you are in the case. Is it something that I actually deal with right now? Do I have to get a few more steps, in before I can kind of go and address it best? Tell yourself, just kind of reinforce yourself that this is going to be the best chance that anyone ever has to fix it right now, right here. And that you have the skills, you're the problem to fix it. So don't dwell on the fact that it happened. That'll come later. Just basically say, okay, this is part of the case now. How am I going to optimize the situation? And don't, I think about it too much or get too frustrated until afterwards, because that's not going to help you solve the problem. Okay, so I think Pearl's number one. There's no substitute for a good primary closure, is what I should have on that. Number two, there's no substitute for a good primary closure. And then number three, yeah, you got it. No substitute for a good primary closure. So optimize the primary repair. What that often means is that you may have to expand the incision. You may have to remove more bone. You really have to see it. You have to have a good understanding of what it looks like. Is it a bleb? Is it something that tracks ventral? Is it something that tracks underneath the caudal lamina? You do have to see it. Sometimes that will actually make it worse in the short term. Say it's a bite, at the caudal extent of the ligament, and you have to remove some of the caudal lamina to see it better. Well, it's going to start leaking more, right? Because you've removed some of the pressure. But ultimately, you'll be able to repair it more thoroughly if you can actually see the entire injury. You have to drape the scope. I think that, with very few exceptions, having a microscope is going to help you close it better. The one exception may be in the cervical spine. I think for posterior cervical CSF leaks, usually you've got such a good exposure, you may not need the scope. Likewise, if you're doing big open deformities, you may not ultimately need it. But I think for the vast majority of cases, the scope is going to be helpful, so you can just really see things well. You should have a set of micro instruments available to you. So we have like a little tray. I think it's actually Eastlack's tray, but I just asked for it. It's his micro instrument tray, and has all the little, freers and dissectors that might help you kind of get the dural leafs closely approximated. Obviously, I do most of my decompressions through tubes. There are certain instances, although pretty rare, but there have been instances where I've basically taken the tube out and just converted it to a traditional open, so I can get a better look at it. And I would have, a low threshold for doing that. I think converting to an open is a smaller cost to the patient in terms of their recovery, as opposed to inadequately repairing a leak. And there's a wide variety of different materials and instruments for repair. We'll talk about some of them, but you have to figure out what works best in your hands, and have that available to you, so that you can get it, just by asking the circulator without a whole lot of fanfare. Okay, so what about suture choice? This is something that at least in neuro, folks think about a lot. Some will use 4 O's, 5 O's, 6 O's. Obviously, the smaller the needle, the less of a hole in the dura with each pass, but sometimes they can be a little bit difficult to handle. Certainly, you're going to want a needle that has a pretty significant curvature just so that you can turn it, particularly if it's a deep hole or a tube. Gore-Tex and Prolene are pretty strong, but they're and non-absorbable. So a lot of neurosurgeons will advocate for that. And importantly, you don't want the suture to be larger than the stitch. And so if you've got a relatively thick needle and a thin stitch, then you're going to just by the virtue of physics, you're going to have a bigger hole than the suture will hold. So, or than the actual stitch will hold. So you want to make sure that the stitch isn't smaller than the needle itself. And most of these 5060s are going to have that. I use a silk. This is a picture of one of my mentors, Paul McCormick, who does as much intradural spine stuff as probably anyone alive. And he uses silk. They're not necessarily as strong as Prolenes and Gore-Tex sutures, but they handle really well. It's really easy to drop knots down. And I think, whether it's Gore-Tex or Prolene or silk, I think getting a good closure is more important. So I can't really remember going back in to revise a durotomy repair where I see that like the sutures have disintegrated. It's usually that you don't get good opposition of the dural leaf. So I think just figuring out which stitch works best in your hands is important. I prefer 50 silk just because that's kind of what I was brought up on, but you can use whatever works best for you. What about sealants? So there are two primary sealants. There's Duraseal, which we have at Scripps. Stryker has a product as well. I don't know that there's really a significant difference in the efficacy, but it is something that's used very commonly. So the most common technique when folks use sealants is they'll do some kind of primary closure, which I think is the most important, regardless of what you do afterwards. And then they'll use some sort of patch or graft and then a sealant. And that did result in the lowest rate of recurrent leaks. But if you look at the sealant alone, it doesn't significantly reduce the rate compared to just a primary closure. So it's something that we use, and it does slightly increase the success rate, but not statistically significantly. And it doesn't seem to have a big outcome deficit or infection. So I do think it's helpful, but it's not something that's a game changer. And if you don't have a good primary closure, the sealant's not going to save you. So, like there's a lot of different techniques. Do you do the stitch and then put the DuraGen and then seal over that? Do you do the primary closure, then put the sealant and then put the DuraGen on, chicken before egg? I think that, there's nothing in the literature, at least, that would suggest one is superior to the other. I can tell you that in my own hands, I prefer to do the primary closure and put the patch, the patch options. And then when the patch is in place, then I'll use the sealant. And the idea there is that the sealant, I don't think the sealant will actually prevent the egress of fluid. I also worry about if the sealant gets in between the loops of the dura and actually prevent proper healing.
It garbles.
It does a good job of holding the patch onto the dura. So I do patch that sealant. Would add.
Andy, you're garbled, buddy. You're losing bandwidth.
Can you guys hear me now?
Yeah, it's a little bit iffy. I don't know, it just dropped off for some reason. Might be.
Give it a second. Anybody?
Try.
Okay. I'll keep going. Bob, if it gets
better.
really gurgled, would you? Okay.
Yeah, I'll let you know. It sounds
So
good.
I'm not sure exactly how. Okay, cool. I'm not sure how much of that you all lost, but the takeaway point was that there's a couple of different ways to do it. I advocate for primary closure, followed by the patch, followed by the sealant, DuraGen, or excuse me, Duraseal, or whatever your sealant is. And the reason is that I fear this could prevent the dura from healing properly, and it does help keep patch on the dura. There is this, I don't know, there's been a couple of attempts to try to use clips, and there is some data that suggests those clips are really strong in lieu of sutures, but I think that they can be very technically difficult to employ. So that's not something that I would advocate for or have really ever utilized.
It seems funny, isn't it? I mean, the primary issue is the dura viability in the repair, not the repair agent.
Yeah.
Like you don't need stronger material holding the dura together. You need stronger dura.
Exactly right. It's not like the sutures are failing. So it makes it a lot easier to deploy. I don't really see the advantage, and certainly do have it's lateral, but it's a technical difficulty. That's going to be immense. So I wouldn't.
You're garbled again. Still garbled.
Okay, if you guys give me 1 second, I'm going to call in from my phone and see if I can improve
It's
that.
better now, whatever you did. Recap. All right, good.
Okay, how's it now?
Sounds okay.
Can you hear me now?
Yeah.
Yeah, sounds good now.
Guys?
Yes, we can hear you.
Okay.
You can't hear us.
So, okay, great. This is Durastat. This is great. So this is Durastat. This is something that I do think is helpful, and it's a relatively new instrument. But what it does is it preloads the stitch and it places it at a really severe angle, so that if you have a durotomy that's lateral or by the nerve root sleeve, you can basically get the needle inside the thecal sac under a little bit of tension and then just fire the button and it throws the stitch. So I think it can be really helpful. And it's an important thing to have in your hospital, but it's really expensive. It's like $800 for a single stitch. So it's something that you want to employ in a very limited capacity. But I do think, if you compare that cost to the cost of an improperly closed durotomy, it is probably something that could be cost effective. So have it, but use it sparingly, only when you need to. And if you ask the company to give you a few just so that you can practice, on like a model, they'll let you do that. So I think it's something important to have, and it's something important to understand in terms of how you actually throw these stitches before you burn $800 and open one. Okay, so this is a newer, I guess, implant or compound that was primarily developed for vascular tears. Excuse me. And the cool thing about this, what I think makes it different than Duragen, because the actual substance is not really any different than Duragen. It's just, yeah.
Oh, that's super delayed. I think he just heard you.
Yeah, it's a delay. Go ahead.
You can't hear me?
Yeah, we can hear you. Go ahead.
I'm going to sign in on my phone.
Go for it.
This is Microsoft.
Okay, so I was just saying that so TachoSeal is a newer product. It's not very much different than Duragen in terms of the actual structure. It's just a collagen-bound matrix. The difference is that it has an adhesive portion, and so that yellow structure there, if you apply pressure, will actually adhere to the dura. And I think that makes it important and different than Duragen, because sorry about. Okay, so I'm logged on my phone now, and I think that'll make it a lot easier. the actual structure. It's just like
Yeah, you want to turn your computer off though.
The difference is that it has an adhesive portion. And so that yellow
Which Hani are we getting?
structure there, if you apply pressure, will act. Okay, now you guys should hear me live.
Yeah. Much better.
Okay, so what about the drain? I do think that the drain is pretty important. Turn my volume down. And the reason is that basically when you have a subfascial drain, then it's going to allow you to get a sense of what's going on in the subfascial space. And you can always clamp it to prevent egress of fluid. But if you also have this one-way valve effect where CSF is getting out and can put pressure on the nerves, then you can always use the drain as a way to drain the fluid out. And this is just a graphic of how CSF can create a pseudomeningeal seal. What about flat protocol? So for all lumbar cases, I think it's really important that patients are flat postoperatively. There's some discussion about whether or not it makes sense to do so in the cervical context. But if you think about it, the water column of the CSF extends all the way to the ventricles. And so even for folks that are dealing with a cervical CSF leak, it's probably important to have them flat for a period, although it's not as critical as it is for lumbar spinal leaks. When do you place a spinal drain? I think, in short, if there's a question about whether or not you need to place a spinal drain, then there's probably a good chance that you need to place a spinal drain. And if when you're done with your repair, there's still visible CSF leakage, then I do think it's important to be ready to place a spinal drain. It's not a hard procedure, especially if you're in the operating room and have fluoro. You can do it in the lateral decubitus position, or you can do it prone on a Wilson in the OR. You can do it with conscious sedation. When you are placing it, usually depending on where the leak is, you're going to want to go above or below, and you want to obviously just be caudal to the conus and just look for that interlaminar space. This is just a picture of the different supplies that you need to place a spinal drain, but I think before you finish your fellowship year, just kind of get with me and we can go over all the different pieces. We also have a Google Doc that goes over all of this. And what about the protocol? Usually, if you place a spinal drain, that means that the patient should be flat for 2, maybe even 3 days. They can get to 15 degrees for meals or to use the bathroom. I do 12 Q2, so 12 cc's of spinal fluid every 2 hours. There's variance in the literature everywhere from 10 to 20 cc's. It has to be a rate that the patient will tolerate. So if they're having headaches while they're flat, then that's too much and you have to go down. Some of my partners would like to keep the spinal drain open and then try to titrate the height of the bed to allow for the amount of drainage to be correct. That's asking a lot of the nurses, and I always worry about over drainage. So I just have them do 12 cc's every 2 hours and then keep it closed otherwise. So there's an important thing called the limitor, which basically will stop draining if you drain more than 20 cc's. This is really important. There, unfortunately, are reports of spinal drains that were left open, leading to significant overdrainage, subdural hematomas, and then you can get into a really, really dangerous situation. So these limitors prevent that and are really critical to limit the potential damage that can be done if a nurse isn't familiar or makes a mistake or leaves it open by accident. So that's all I have. I'm really sorry about the technical difficulties, guys. Hopefully able to hear most of that.
Hey, Hattie, do we have those volume limiting systems here?
Yeah, we definitely do. They're behind OR 10. And in general, if any of you guys have these, I'm always around. But if you have it done in IR, they'll place the limitor. In the OR, we have them.
So these limiters are in they're not part of the drain kit, is that right? Or they are part of it?
Unfortunately, it comes in like 3 different boxes. So there's the actual like Tui needle, and that comes with this little guide wire that you can thread into the spinal drain. Then there's a separate box for the collection system. There are 2 collection systems. There's the EVD collection system, which does not have this limitor. And then there's the spinal drain collection system, which is literally called Limitor, Limotor, I think. And we never run out of them. If there's ever any question, just shoot me a text and I can either grab one myself or have somebody from the neuro team bring them to you. But they're really important.
That's awesome. Thanks, Hanny.
Sorry about the technical details, guys.
No worries. Worked out great. Good. It's great talk.
Any of the fellows, you guys, hopefully we haven't had too much experience with this together. Nick and I are dealing with a gal right now that had this strange sort of epidural arachnoid cyst, probably from a lumbar puncture years ago, and she's got a spinal drain in, and so he and I have had some real life experience with it recently. But
She just represented last year.
Yeah, I remember.
She's leaving.
Yeah.
So you took it out already?
We're going to take it out today. So her case was kind of interesting because there's like one pedicle where the dura was communicating with the cyst, but then the dura around that pedicle was just like really ratty. So I think it's probably just sort of seeping through that. Or there's another leak somewhere else lower but I'm kind of surprised. I mean, it seemed like it was watertight at the end, but she definitely was having some headache. So
With the drain in, huh?
yeah.
You flat still right now.
Yeah, I'm going to get her up today and hopefully pull the drain.
And you have a subfascial drain in her too right now, so you know
I
she's
do.
got rest.
Yeah, I like that a lot. Now the subfascial drain is clamped, and basically the rationale is if there's a couple reasons I like having the subfascial drain is one is if there's a CSF leak and they're not having any symptoms, but I see pinkish stuff coming out of the drain, I just put it on gravity. Importantly, I never put it on compression. Well, then I know that there is still a leak, and I just have to see if it's something that they're going to be able to tolerate clinically. By comparison, in this gal, for example, she's got a lot of potential space around the site of the cyst because it expanded her lamina. And so if I get her up today and she's not having any issues, I'll probably pull the spinal drain, and then tomorrow I might open that drain to gravity just to kind of decompress the pseudomendingocele a little bit. So you just kind of have to think about the push-pull, but I always like having the drain because if they do have any issues related to compression from the pseudomendingocele, it gives you an option to decompress that. And it also just gives you information about whether or not there's an active leak.
And are you putting drains in all of your micro decompressions?
No.
Just the bigger voids? Or
Yeah, exactly.
How do you differentiate?
Well, if I'm concerned somebody has a CSF leak, then I'll always place a drain, because I want that information about whether or not there's still a leak. But it's always on gravity.
So
And if
always, even if you've repaired it.
Yes. Yeah. Because like if I have the drain on gravity and it's not putting out any fluid, I'm pretty sure that they're good and I can get them up and mobilize them, day one. If I put the drain on gravity and there's some fluid collection, then I may clamp it and see how they do. But at least then I'm not kind of like trying to determine whether or not they're going to fly. I actually know whether or not there's any leakage. Now, the downside to that is obviously if you have a pseudomendingocele that applies pressure and prevents egress of fluid, that's going to allow the dura to heal more quickly. So once I know there's a leak, then I clamp the drain. But I do like having that information. But I don't think, certainly you don't want to keep the drain open if you know there's a leak. So you just kind of have to be ready to clamp it.